All right. Hi, and welcome to our live stream. So, we are doing this live stream on covering the basics of IV fluid prescribing in children. I am not with Henry Goldstein as advertised, as you can see, but I have some may say even lovelier than Henry, Dani Hall. So, thanks for joining me, Dani.
Oh, thank you. I don't think that you can say I'm lovelier than Henry, but I'm very pleased to be here. So thanks, Tessa.
Well, we won't spend time going into the pros and cons of both of you. You are both special in your own way. So we should be live on YouTube and Facebook, and I can see there's some people watching, which is good. And just so the people watching know that we should be able to see your comments when you post them, and we will be able to answer any questions. And it would be nice to hear who's out there and who's watching. So we'll try and answer any questions.
Cool.
So
really looking forward to it.
yeah, so we're gonna go through the basics. So the first thing I think is to think about weight calculation, because the whole premise of IV fluids in adults is simple because it doesn't really matter what they weigh, you just have one thing to do, right? But in kids, it's going to depend on the weight. So how do you go about checking the weight, or if you can't check, what do you do?
So, well, the easiest obviously is to weigh the child. And normally, if they're well enough when they come in, they can have a weight and triage. If they're old enough to sit on the scales, we have scales with a special chair. Or if they can stand, then that's ideal. Sometimes they're a little bit frightened, so this is the time for the parent, mum or dad, not to feel embarrassed about their weight. But we'll get them to be weighed together, and then we'll weigh the parent on their own, subtract it, and then you've got your child's weight. Clearly, that's the easiest way to do it, because you've then got today's weight, and then you can do your fluid calculations on that.
Yeah. So yeah, sometimes there is an old weight on the system, isn't there?
Yeah, exactly. Especially kids who've been here very recently. Sometimes with the children who have lots of weights for various reasons, they might have complex needs that they're weighed for regularly. The parents know their weight, and that's also very easy, very accurate, because if they've been weighed in the last week or two, you can go for that.
Yeah. And I suppose if you're thinking about dehydrated kids, though, you would need to be a bit wary about using an old weight, really.
Well, that's very true, because if they're dehydrated, then they'll have had a lot of fluid loss and fluid weighs. So today's weight will actually be a lower weight than their usual. And to try and get it as accurate as possible is really the best way to do it.
Yeah. So, but sometimes you can't for whatever reason. So what do you do about if you have to estimate the weight?
Well, there are different ways that you can do it. I use the APLS formula now. That they've changed since I started my training, and I always have to look them up. They don't stick in my head anymore. But the one that we're currently using is the more recent APLS weight estimation, which for children under a year of age, you get their age in months. You divide it by 2 and you add 4, and that's meant to be the weight of an average child of that age. And for the children who are over a year old, it gets a little bit easier. So for the 1 to 5-year-olds, you do their age times 2 and then you plus 8. And for the 6 to 12-year-olds, you do their age times 3 and you plus 7. Now, I can never remember those. I have to look them up every single time. Tessa and I will both agree that the older APLS formula was a lot easier to remember. And it was one for all children over the age of 1. But yeah, so in your sicker child who you just can't get them on the scales, using an estimated weight is a much, it's a good way to go forward.
Yeah, and I think from anyone who's watching, it'd be good to hear what you use, because yeah, me and Dani both use age in our heads. We just would do age plus 4 times 2 because it's so easy, whereas the new APLS thing's really complicated. And plenty of places will have cards or other easy ways to estimate. So let us know in the comments what you guys are using. So we've calculated or estimated the weight, or actually weighed the child. So then it comes to calculating maintenance fluids. So what situations do you find that you're normally having to prescribe maintenance fluids in ED?
So for me, it's the children who, I kind of put them into 2 groups. The children who can't tolerate things by mouth, so we need to give them their fluids intravenously. So they might be children who maybe have a bad gastroenteritis and they're vomiting and they just can't keep things down. And so giving them enteral feeds by mouth just isn't really an option. Or it might be the children who have a surgical presentation, or children who are actually a bit too sick to give them oral fluids because for whatever reason you want to keep their stomachs empty. The classic would be a child with really severe respiratory distress or really bad sepsis that you think actually might need to be intubated, and the safest way to do that is to keep their stomach empty. Those are the two broad categories for me that I'm giving IV fluids to.
Yeah. And I'll just mention Chris. Hi, Chris. Thank you for commenting, and nice to see you. It's been a long time. So Chris uses an app. So yeah, there's probably loads of apps. I don't know, Chris, which app in particular you use, but it's not that hard. If you were, this is about estimating weight, how hard it is to. It's not that hard to actually, estimate, look up and Google it and find a useful resource, because there's plenty out there. So yeah, these are the key times where we need to prescribe IV fluids. So then you come to calculating IV fluids, and I know this can be tricky for people, particularly ED trainees coming from the adult side, having to calculate things under pressure. It can be tricky, and it's not a straightforward calculation, but the more you do it, the better you'll get at it. So there's two versions of this. This is the Holiday-Seeger formula that is called. So there's two options. So which do you prefer to use? Shall we say that first?
So I don't know why, but what I do is I calculate their fluid requirements over 24 hours, and then I divide it by 24. The other option that a lot of people use, and probably is just a little bit simpler because there's one less step to do it, is to calculate their hourly fluid requirement, and then you've just got it and you can prescribe their fluids per hour. Okay.
So if you were doing the 24 hourly, which is what you do, how do you do that? How do you work it out?
So you have to break this child's weight down into weight brackets, really. So the amount of fluid that you give, you have to think of them as 10 kilogram aliquots of weight. So for the first 10 kilograms of the child's weight, I'm going to give 100 milliliters per kilogram. Then for the next 10 kilograms, I'm giving half of that. I'm going to give 50 milliliters per kilogram. And then for every kilogram of weight on top of that, I'm going to give 20 milliliters per kilogram. And so you're giving it exactly as you put on the screen: 100 for the first 10 per kilo, 50 for the next 10 per kilo, and 20 for every subsequent kilo after that.
Yeah. And it sounds confusing, but actually if you've got a child who's over 20 kilos, then you know that for the first 20 kilos, you're going to have 1,500 mils, and then you work it out after that, right? So it's quite easy. And that is the way I do it as well. So that's your 24-hour requirement. And we'll go through a couple of examples. But the other way is to do it hourly. Mm-hmm. So what's the difference? What do you do when you're doing it hourly?
So rather than work out their 24-hourly amount and divide by 24, you just can do it per hour, and that's for the first 10 kilograms, you give them 4 milliliters per kilo. For the next 10 kilograms, you give them 2 milliliters per kilo, and for every subsequent kilo after that, you're giving them 1 milliliter per kilogram.
Yeah, so it's 421. So you've got 150, 20 for your 24-hourly calculation, and 421 for your hourly calculation.
Yeah.
Okay. And shall we go through an example of that just to see how it works? So let's say we're using, what should we do first? What example should we use?
Why don't we do 14 kilograms? Why don't we do one that's less than 20 kilograms? Let's say we've got a child who's 14 kilograms. So let's work out their fluids. For the first 10 kilograms, we're going to give them 100 milliliters per kilogram of fluid. And they don't have another 10 kilograms for us to do the 50 per kilo. We're down to the next 4 kilograms. So we're going to do 50 milliliters times 4 rather than times 10 now, which is another 200 milliliters. So we've got 1,000 milliliters for the first 10 kilograms, 200 milliliters for the next 4 kilograms, and that's 1,200 over the 24 hours, which then works out to 50 mils per hour.
Yeah, so it's going to be 50 mils per hour, and that's how it's broken down. So, and then should we do one other example?
Why don't we do one with a child who's over 20 kilograms this time, so that we can show the additional step. So let's say we've got a 24 kilogram child. For the first 10 kilograms, we're going to give 100 milliliters per kilogram. So that's 1,000 mils. For the next 10 kilograms, we're going to give 50 milliliters per kilogram. So that's another 500 mils. And then they're 24 kilos. We've got 4 kilograms to go on top of that. We're going to give 20 milliliters per kilo. For the next 4 4 kilograms, which is 80 mils. When we add it all up, that's 1,580 mils over the 24-hour period, which when you then divide it by 24 to give you an hourly rate, it's just under 66 mils per hour.
Yeah. So, so each time you do have to work through it. It's not like nobody's going to say that, they can just do it in their heads. So all of us will sit down with a pen and a piece of paper and work it out. So, and that's fine. But it's good just to do these examples. And also, at the end, you should have a rough idea of what it should come out like. Like if you're calculating 200 mils an hour, then you've probably done something wrong. And yes, Chris, it hasn't changed since you learned maintenance fluids. It's been the same for many years, which is good. But I think it's difficult. If you don't prescribe for kids often, then at that time, even if it's been 6 months or a year, it can be really tricky. Okay, so we've given a few examples of how to calculate fluids. So what choice of fluids are you going to use? I don't think we're going to talk about this in a huge amount of detail, but let's just, when you're prescribing, if you're asked to prescribe maintenance fluids for a child in ED or indeed on the wards, in the situations we've described, what is your go-to choice of fluids?
Okay, so there are some special circumstances where your fluid choice is going to be different. I'm not going to talk about those. My standard is to give normal saline with a mix with 5% dextrose. That's giving them their electrolytes, but it's also giving them some sugar at the same time. So they come in pre-made bags, 0.9% saline with 5% dextrose. I don't put electrolytes in the first bag unless I've already got a blood result that shows me that they need additional potassium. But if they do need potassium, if I know that their renal function is okay and the potassium level is low, then I'll add in 20 millimoles of potassium into that bag. Just remembering that this bag is going to last quite a long time, so I want to keep an eye on their electrolytes before I put the next bag prescription up.
Yeah, I think it is a bit tricky in ED because you do prescribe fluids and then they do go off somewhere and you are not going to be the person checking on them. So how do you feel about that? Do you just, the ward will pick it up and should look at it again, but in a way you are really responsible for that bag going through over the next however many hours.
Yeah. Exactly. And so that's all around the handover, isn't it? And explaining why you've given, potassium or not given potassium in that particular bag. Maybe you have got your blood results back. Maybe this was a child with gastroenteritis, for example, who you were trying oral fluids first and they didn't tolerate them, by which point you've got some electrolytes to make your judgment on. But it's all around making sure that is communicated really clearly so that your prescription that goes forward when the child has left the emergency department, someone's keeping an eye on it. Exactly.
Cool. Okay, so we'll move on, and I can see there's some more new people have joined to watch, so please post your comments or questions and we will answer them here, because we're not just having a chat with each other, we are here live, so we can hear your questions. So you mentioned about oral fluid challenge. It's probably a good time to talk about it now. Because often we have kids who come in with vomiting, diarrhea and not drinking at home. And we do have this question, should we just start on IV fluids or should we be doing a fluid challenge? How do you feel about that?
I always think the best place for a child is at home. So we'll admit the children to hospital who need to be admitted, but actually if they can manage at home, then that's a much better place for them. It's nicer for them. It's their own home environment. It's nicer for the parents. So I'll always, unless they're so dehydrated that I think they actually need fluid resuscitation, or if I look at them and think this is a sick child who I need to have in hospital because I need them to be on monitoring, I'll give them the benefit of the doubt and we'll try some fluids. And we normally, in our department, actually, we like apple juice or dilute apple juice because the evidence is showing that actually that's tolerated very well and probably tolerated better than Diarrolite. And other departments will use Diarrolite or other oral rehydration solutions. And so being able to explain to the parents that what I don't need this child to do is to have a really big drink now to show me that they can have a big drink, because that might make them vomit. What I really want to see is, will this child be able to take small aliquots of fluid regularly and keep it down and be able to maintain their hydration at home?
And there's two parts to the fluid challenge, or why you're doing it, because one is, do you know that the child will physically tolerate it? So are they going to vomit everything back? Because then if you send them home, there's potential for them to get worse or dehydrated. But I think I find that a lot of the times is for parental confidence building. Because, you know, when you've got a young kid who's not drinking fluids at home and they don't want to drink fluids, then the parents are it's really difficult for the parents to persuade them to drink. And you know, your kids are a bit older now, so are mine, but persuading a toddler to do something that they don't want to do is really difficult. So you need to be able to have the parents be able to send them home that the parent can actually get them to drink. And so I think that principle of saying small volumes and often is really good. So they know that they don't have to get them to drink like their whole bottle. And if they can see that they can do it in ED, then they'll be able to do it when they get home. Yeah?
Yeah, exactly.
Okay. So as far as guidelines and strict guidelines, we don't actually tend to use Diurolite that much, I would say, unless we're really worried about the kid. And I just use an estimate. I know we were having a look before. Did you find any guidelines that people have on specific volumes for oral fluid hydration?
So that it doesn't look like there's any real consensus. I looked at a few different hospital clinical practice guidelines, and some of them are saying 5 mils every 5 minutes. Some of them are saying, 1 to 2 milliliters per kilogram over 10 minutes, every 10 minutes. But those volumes are then getting a lot bigger. For me, I don't think it really matters the actual volume that they're taking per amount, as long as, I'm confident that over the course of a few hours, they will get enough fluid that they would normally be having for, over a few hours at home. And it's more exactly as you say, showing parents that the child can do it and reassuring myself that they can do it as well.
Yeah, I think so. Chris has asked a question if there's any particular dilution ratio for the apple juice. I know there's a typo in this. He's corrected it to hydrolyte. So he's saying that he's used hydrolyte, which will be a version of diurolite. So what do you do with apple juice in your ED?
So there's different, again, it was, I can't remember the name of the authors actually, but there was a brilliant paper a few years ago that showed that kids tolerate it really well. We do about half and half. It's not very strict. And for the kids that actually want some apple juice, I'll often just give them a carton of apple juice. We have tons of cartons of apple juice in my ED. That I don't think there's any hard and fast science that people have looked at different dilutions to say that one is superior to another. And I think the most fun is for the little babies who've never had apple juice before. I'll make that a lot more dilute because this is a big sugar hit that they just haven't had. But normally I go about 50-50.
Yeah. Sabrina suggested coconut water, which it seems like a very luxurious option. I don't think it's going to be one that we'll be using. So yeah, but if you've got it available and the kids will have it, that's fine. But we don't. In East London, it's not something that we have. Amanda said, "What about ice pops?" And ice pops are amazing, right? So in Australia, this is like what they use all the time, and we think about ice pops less in the UK. But they're such a good option because kids love them. Right? Even if you're feeling a bit off form, you will be happy with an ice pop. And if you've got a sore throat, they feel cool. That coolness probably have some sort of analgesic effect as well. And it's just a great way to get good fluids into a child. So I absolutely love ice pops. Unfortunately, our freezer's often empty in the hospital for them. But if you've got them, then I think that's really good. Do you use them where you work, Dani?
No, we don't. But it's a little bit like we were saying before. There's no hard and fast rule. We just need to get fluids into this child. So if I've got a child and the mum says that they don't like juice, but they'll take milk and they've got their milk with them, milk is fine. That's their ideal if they're younger. So yeah, ice pops. I would love an ice pop. Maybe we should have them for staff as well.
Who doesn't love an ice pop? So yeah, I think whatever works is fine, because the key with most of these kids is we're not literally rehydrating them. There's different types, isn't there? So it's different if you're actually trying to rehydrate a dehydrated child with oral fluids, but that's not really what an oral fluid challenge is. An oral fluid challenge is to see if they'll tolerate oral fluids, and whether that's because the parents have struggled to get it in or because they might be vomiting. So it's less about the volume or the type of fluid and more about demonstrating that they can drink it and tolerate it. So I agree with you. If they like milk, if they like coconut milk, if they like whatever, that's fine. That's what we need to try and get. So we've just had a question about anti-emetic use, which I think is a really good question. So it's maybe slightly off the IV fluids topic, but I think it's a good question. So when we've got these kids and they're vomiting, we're trying to give them an oral fluid challenge and they're vomiting. If you will have the option to consider giving them anti-emetics, so giving them some ondansetron or something like that. Is that good enough to reassure yourself that they could then drink and go home? What would you do, Dani?
No, that's brilliant. And hi, Fahim. For me, I think it's around getting the diagnosis right, because there are some children that come in and they've got some vomiting and you think it's gastroenteritis, but it's not. So what I don't want to do is mask a different diagnosis and reassure myself that this child is now tolerating their fluid and off they go home, and actually there's something else going on. I'm a bit more confident using it if there's also diarrhea or if there's a history of contact with someone else with gastroenteritis, maybe a sibling also has it. And I will normally start their fluid challenge without it and see can they manage on their own. If they really can't, but the child is otherwise well and there's nothing else that makes me want to bring this child into hospital, I'm very happy to give them a trial of oral ondansetron and see if that turns them around. Now, I haven't looked in any detail at the evidence to see does that keep them out of hospital or do they just represent later when the ondansetron effect is worn off. But my kind of feeling is that once they're home, they don't tend to represent, but I don't know the hard science behind that.
Yeah, I think it's just variation of what you're used to as well, because when I trained in Sydney, we gave everyone ondansetron when they were vomiting. It was totally fine. Yeah. They were fine. They drank. They went home. They didn't come back any more than they do now. Whereas I think here, where I've worked, they definitely were a bit more like, are we just covering up a problem? So then, because obviously they're not going to go home with ondansetron. So if we just show that they can drink with ondansetron, is that really helping the parents at home? But actually, when we used it in Sydney, it was totally fine.
I think a lot of it, though, and this is again straying a little bit from IV fluids, but when you become dehydrated, you become quite ketotic and you need fluid back in and a bit of sugar back in to kind of bring that down. The ketosis is just going to keep driving your vomiting. So if you can at least get some fluids into them in the emergency department, you're fixing their physiology enough for them to feel better, drink more, home they go, and you kind of reset things a little bit. So I do like ondansetron, I do use it. I just want to make sure that I'm confident that I'm treating the right thing. If there's any question that maybe this is surgical or another presentation, then I'm not going to give it.
Yep. So there's been a bit of ice pop commotion on the chat. So this is outrageous suggestion that all the staff are eating all the ice pops themselves and there's none left for the children.
I wish.
I cannot confirm or deny. And then Fahim is going to do an ice pop quip, which is good.
Very good.
So that we can have an ice pop DFTB quip. So thank you, Fahim and Tara. Fahim, I'm glad you're enjoying the YouTube channel. Thank you. And then Sabrina said that it's actually easier in in tropical countries. It's easier. I'm not sure what does. I'm not sure, Sabrina, what the comment is, but I think what I found was that in the hotter places when I worked in Australia, we had more availability of ice pops, whereas probably less something that we think about in ED. So I think we've covered fluid hydration, we've covered types of oral fluid challenges, and I think the next thing is thinking about what happens when we can't orally rehydrate them. So we will only continue the live stream until past. So we want to try and get through. We'll try and keep them to 30 minutes so that you know how long you guys are committing to watching for. So I think this discussion obviously is quite a good one about oral fluid hydration. So maybe we'll come back to it another time. So when you can't rehydrate them with oral fluids, maybe it's not working, they're vomiting or they're looking more unwell, then it comes to thinking about dehydration and how to assess dehydration, because the next part of the fluid calculation is calculating, if you were giving IV fluids, is to add on the rehydration elements. We've talked about the maintenance element. So deciding whether a child is dehydrated or not, what's your framework for doing that?
So I tend to categorize them into mild, moderate, or severe. And the mild, I'll say that less than 5%, moderate 5 to 9%, 5 to 10%, and severe is when they're really, really, really dehydrated. We're kind of straying into the realms of shock at this point. So those are the kids that are in resus. It's a different conversation. There are lots of different guides out online. NICE in the UK have a guide. There are various ones in different jurisdictions that will give you different signs that you'll want to look at to decide, is this a mild dehydration or a moderate dehydration? And it's things around, is their heart rate normal, or are they a little bit tachycardic? Same with their respiratory rate. What their skin color and their refill time is like, what their mucosa are like. Are they moist, or are they not? Do they have warm extremities, or are they a little bit shut down? Eyes are a big one. So do they look normal, or are they a little bit dull and sunken? Skin tegel, that is a bit tricky in children because they tend to have quite good skin tegel even when they're a little bit dry. But the different guides kind of pull those together, and if you're predominantly in the category of mild, then I tend to say 5%, and if they're predominantly in the category of moderate, then I'll say up to a maximum of 10%.
Mm-hmm. Okay, so once you've worked out their fluids, how dehydrated you are, you then have to calculate the volume that you're going to rehydrate for that.
I think this. Yeah, go on. Oh, sorry, Tessa. I was going to say, I think this is where people get a bit more confused, because this is additional fluid. You've got your maintenance, which is what you just need just for day-to-day normal physiological activity, but then adding your maintenance on top is another calculation, and then you add them together. But we can go through that in just a sec.
Yeah. Okay. So let's talk about that then. So how are we going to? So we've talked about the maintenance fluids. Okay. So we know how to work out 24 hours maintenance fluids. But let's say we've got a child who's 10% dehydrated. How are you going to actually work out that?
Okay, so I take their weight, and then you times it by the percentage that they're dehydrated, so times 10, and then you need to add on another factor of 10 because you need to convert it to milliliters rather than a percentage. So for the 24 kilo child, it'll be 24 times 10 times 10, and that's your 24 hour or 48. We can discuss how quickly you give that, but that's your dehydration correction.
And I think Joanne Riley's posted a link in the comments on Facebook to a good fluid calculator, and there's plenty of good fluid calculators online. And in fact, I think Danielle Hanlon said that in Australia they've got which we actually have a version of in our hospital. On the back of the chart, you've basically got a guide to how to prescribe, and they tell you the step by step. So I do think these aids really help, but I do think it's important to know what you should be calculating, because it means when you come to the end of the calculation that you know that you will pick up any errors when you're going through that process. This is how we do calculate the rehydration, or how much rehydration IV fluids you would need. So you're looking at the percentage dehydration times their weight in kilos times 10. And I think it is the times 10 that people always forget or get confused by. You have to times it by something, but what is it? So why are we adding this times 10, Dani?
Because you're talking about milliliters, which are in thousands, and your percentage dehydration is as a percentage out of 100. So you just need to do that extra conversion to get it into milliliters, basically.
So you gave the example of the 24 kilo child we were talking about. So they're 24 kilos. We'll say they're 10% dehydrated. Okay. Yeah. So that will be 240 mils, and times 10 is 2,400 mils. Okay.
Yeah.
So it's quite, when you calculate it, it can be quite a lot, and that's fine. But it seems, because what did we say for that 24 kilo child, that their maintenance fluids, so they were getting 1,580 mils over 24 hours, and then they've got an extra 2.4 litres on top of that that's rehydration. So it's a lot. So you will work out the hourly rate that you want to give that and add it onto your maintenance fluids as well. And we'll just tie up by saying, are you going to give these over 24 or 48 hours?
It depends on the child and how quickly they've become dehydrated. So if they've got a very short history of whatever illnesses or has caused them to become dehydrated, I'm happy to give it over 24 hours. If it's been going on a few days and I think that they've become dehydrated over a few days, I'll give it over 48 hours. And I think the main thing really is that communication piece. For me in the emergency department, I'm not going to be monitoring this child long term on the ward. So communicating with the ward team about keeping an eye on electrolytes, like we said before, keeping an eye on their urine output. If they have huge urine output, then we're probably overdoing their fluids. If they're only peeing at maybe 1 ml per kilo per hour, then you're probably about right. And just tweaking things as needed.
Yeah, I think so. So the over 24 or 48 hours part isn't an exact science, unfortunately. So it's just make a sensible clinical judgment, make sure it's reviewed, make sure the child's urine output, electrolytes and so on are kept an eye on, and review it after that.
Yeah.
Okay, so I think we will tie things up here. What I'm trying to do on the channels here is that every Thursday at this time, which is 10 a.m. in the UK, we're having either a YouTube video being released or we'll do a live streaming session. So for the people watching on Facebook, you can go to the YouTube channel and see what stuff we've got there. But please let me know what other things you'd like us to, other topics you'd like us to discuss. Because we're flexible and we're open to suggestions, so what would be good to discuss. So today, thank you, Dani, for joining me. We've covered IV fluids, we've looked at weight estimation, we've looked at how to calculate maintenance fluids, we've looked at situations where you would give IV fluids, talked about fluid hydration, talked about oral fluid challenges, talked about assessing dehydration and how to calculate rehydration fluids. So yeah, hope you've all found it helpful. Thanks, Dani. It's been a pleasure. Cool. And we will end it there. So bye. Thank you all.
Bye.